Okay. Hello again. Hello, everyone. I would like to welcome Dr. Peter Currie. He's MD, General and Interventional Cardiologist, trained in cardiology in Aberdeen and Edinburgh, Scotland. And he was appointed as cardiologist in 1999. And he's working now as a medical director of a British Association of the Sky Patrollers. And he's a chair of the Drugs and Therapeutics Committee. So please welcome Dr. Peter. Dr. Peter, the stage is yours now.
Okay, thank you very much.
Cheers.
Thank you very much. It's a great pleasure to be here tonight. I spent a little bit of time in your wonderful country with Dr. Mudir Al-Khairala a few months ago, participating in a cardiology conference, and I promised Mudir that I would be happy to help out the Al-Ayen University in any way I could. So it's a great pleasure to come and speak to you tonight. I know that you are you've just started or are just about to move into the clinical phase of your training, and this is a really exciting time. I hope to start tonight with some real basics about the cardiovascular examination. I do hope that you will get benefit from this. And if you like my style of teaching, I will be happy to come back and build on this. So I'm going to do this. This is the building blocks in terms of how I teach my students here in Scotland. So in terms of the cardiovascular examination, the general examination is very, very important. But I'd like to start tonight in terms of examining the pulse. The pulse is our easiest way of assessing the heart rhythm, and indeed the heart output. So it's very important. And I have a little assistant here who's going to help me with some of the demonstrations. Can you all see? There. Yeah, so I don't have Dr. Al-Khairala to help me, but I have this pretend patient, okay? So traditionally we examine the patient from the right-hand side of the bed, and there are some reasons for that. Medicine has evolved, and the right-hand side is the correct way to approach the patient. One of the things I'm going to talk about tonight is, for example, the examination of the JVP, which is best done, the jugular venous pulse, which is best done from the right side of the patient. And also, if there's a problem with the aorta, in forms of a condition called coarctation, you'll get your best idea about that in examining the right side of the pulse first. So traditionally, we check the pulse by feeling over the radial pulse on the right wrist, okay? And I would encourage you to start practicing feeling pulses, your own pulse or pulses of friends or partners, to start to pick up the idea about what a normal pulse is. And we traditionally examine the pulse with the tips of our 3 fingers like this. The tips here, the pads, are extremely sensitive pressure sensors. They're the best bit of the body we have in terms of feeling pressure. And we examine the pulse with our 3 fingers like this, okay? In the old textbooks, they would say that you would semi-compress the pulse with these 2 fingers and feel with the middle finger. I think that is a little esoteric, but feeling with the 3 fingers like this at the radial is the preferred method. Now, when we're examining the pulse, we're looking for 3 things in particular. We're looking for the rate, the rhythm, and the character. Now, I'm not going to go into the character too much tonight. That will maybe be for another time. But the rate is calculated by counting the number of beats over a period of time. So in this country, we're no longer allowed to use watches. So I don't know what the infection rules are in your country, but you may want to get a nurse fob watch that you can pin onto your uniform, or if there's a clock on the wall to let you gauge how long the period of time that you're feeling the pulse. And I normally feel the pulse for a long time when I'm with patients, but
Dr. Peter, sorry to interrupt you. Could you little bit raise the camera, please? Little bit. Could you like lift the camera up a little bit, please?
Lift the camera up, sorry.
Just a little bit. Great.
Yeah,
Great. Yeah. Thank you.
So, to get an idea of the pulse rate, you need to measure for a period of time. So I would suggest to you, want to feel the pulse for 15 seconds. In 15 seconds, you're going to get an idea of what the rhythm is doing as well. And you count out the number of pulses that you feel in the 15 seconds, and you multiply that by 4, and that gives you your heart rate in beats per minute. Okay? So if you are feeling and you feel 20 beats during the 15 seconds that the clock is running, then that is going to give you a heart rate of 80. Okay? So the normal pulse is determined as being between 60 and 100. That is a normal pulse rate. Less than 60, we call that a bradycardia, and more than 100, we call that a tachycardia. So those are the definitions of those terms. Cardiologists sometimes use a term, the profound bradycardia, which is a heart rate of less than 40, which may well, if you find people with a heart rate of less than 40, it may well signify a conduction problem with the heart that requires investigation. But bradycardia and tachycardia and profound bradycardia, you need to know those numbers. 60 to 100 being normal, more than 100 tachycardia, less than 60 bradycardia, profound bradycardia, less than 40. So when you're feeling the rate, you're also going to get an idea about what the rhythm is. So a normal sinus rhythm, when you're examining an adult, you should be able to, in your own mind, predict when the next heartbeat is going to be. So as you feel the pulse, you pick up the rhythm of the heart, and if you can predict when the next pulse is going to be and you feel it, then that suggests that you have a regular rhythm. So regularity is important. If you're feeling the pulse and there is no order to it, it is chaotic. There's no prediction. Sometimes it's a fast, sometimes it's a little slow. You cannot predict. Then that might suggest that the pulse is irregular. And when we talk about an irregular pulse, we clarify that a little further. If a pulse is totally chaotic with nothing predictable about it, we call that an irregular pulse. Okay, that's an irregularity, and that is pathognomonic of the condition atrial fibrillation. It's all over the place. You cannot predict it. It's totally irregular. Sometimes you feel a pulse and it has a pattern to it, but bits of it are missing. So for example, you might feel the pulse going beat, 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 beat. And in that situation, you would say, yes, there's something regular, but there's also something missing. And that particular pattern that I've described there could occur when there are many ectopic beats. And if we had an ECG to look at that, we might find, this is an ECG, that we have a situation like that. where every fourth beat is an ectopic beat. And when the ectopic beats happen early in the cardiac cycle, they force the heart to beat when it's relatively underfilled, and it's often difficult or you do not feel the ectopic beat, and it gives this sensation of a missed beat, okay? A missed beat. And that would give you a regularly irregular pulse. So it's irregular because it's not following the rules, but it has got some regularity to it. So ectopic beats can cause an irregular pulse, a regularly irregular pulse. Okay. So that's the sort of thing that you're looking for in your examination of the radial pulse. As I mentioned, we also want to know the character of the pulse, and I will come back and speak about some characters if you want when we start to go on and talking about specific murmurs that you need to know about. But for the moment, rate and rhythm, concentrate on that. Now, we also examine all the pulses. So we may examine the radial pulses on both sides. And particularly if you do not feel the pulse very well, you may want to move up to a larger pulse. So the next pulse that is commonly in use is the brachial pulse. Now, I've said about measuring this pulse with these three fingers. The brachial pulse is easily felt with the thumb. Now, you may be taught that you should not use your thumb to feel a patient's pulse, okay? Does anyone know, just to engage you all, I'd be happy if anyone could shout out why we might be told not to use our thumb. Does anybody know? Please shout out. Yeah, good. I don't know what your name is, but you've got a hand up. Please speak. You're on mute.
Dr. Mubarak, we got
I guess
one.
because using the thumb could apply stronger force.
That's not the reason that we're traditionally told not to, but it is right. The thumb is well suited to giving you more force with your hand squeezing on both sides than this is. The reason that the thumb is frowned upon is that there is a pulse in your thumb. There is a pulse in your thumb, and in the old days of medicine, the old-time physicians would say, oh, you mustn't use your pulse because you might confuse your pulse with that of the patient. I would say that most doctors, and as you get experience, you will not make that mistake. So to me, it is quite acceptable as you start to examine other pulses to use your thumb, okay? So don't be frightened about using your thumb to feel the pulse, and you may want to feel the brachial pulse. And the other pulse that we commonly feel is the carotid pulse. The carotid pulse, you can all feel in yourself. If you feel the cricothyroid process and press back, you'll feel your carotid pulse there. And in emergency situations, you want to go for a big pulse to find out what's happening quickly. So the carotid pulse and the femoral pulse. Okay. So one of the examination items that we look for is we compare the two radial pulses at the same time to make sure that the radial pulses are synchronous. So both radial pulses are about the same distance from the heart, and so the pulse in both radials should feel the same, and it should happen at the same time. And when you're examining them and appreciate them feeling at the same time, then we call that the pulses being synchronous. Now, there's another area that we want to look at, because if we look at my arm, my radial pulse, that is about the same distance away from the heart as my femoral pulse. So the other pulse that we check is we compare the radial pulse and the femoral pulse at the same time, and we look to exclude a condition or a finding called radiofemoral delay. And radiofemoral delay is where you feel the pulse happening at the radial ahead of the pulse in the femoral artery. Radiofemoral delay. And those two things, so dysynchrony of the radial arteries could suggest disease in the subclavians, but radiofemoral delay is usually associated with a condition. And if I go to the board here, I'll hopefully be able to explain this to you. So if I draw the aorta and the great roots and the great vessels of the aorta, who wants to tell me what the great vessels of the aorta are? Anyone? What these blood vessels here I've drawn are? Anyone putting their hands up?
Coarctation of the aorta?
That's what I'm just about to explain, the coarctation of the aorta. But what are these vessels?
Common carotid aorta and their branches.
Okay, so just to remind ourselves, we've got the aortic root. The first
Yes.
branches of the aorta are the coronary arteries. Then we come up to this, which
brachiocephalic trunk.
brachiocephalic, which gives rise to the right subclavian and the right common carotid. We have the left common carotid and we have the left subclavian. Okay, and as our colleague just said there, when we're looking for radiofemoral delay, we're looking for a coarctation. Now, the commonest place to find a coarctation is where the ductus arteriosus used to be. So you'll remember that in the womb, we don't want fetal blood to go to the lungs. So there are a number of ways of diverting that. You have an open oval fossa, and you have a ductus arteriosus. And where you're going to find the commonest coarctation, which is a condition where there is a kink in the aorta, is around that duct. And that's often found very near the origin of the left subclavian. But you'll appreciate that if there's an obstruction here, so blood is going like that, in the upper part of the body, your blood pressure will be high. And in the lower part of the body, in your femorals, your blood pressure will be lower. And that is the opposite of what we find normally. Normally, the blood pressure in your legs is slightly higher than the blood pressure here. So the finding of a delayed pulse from your right arm to your right femoral artery might suggest that there's this condition called a coarctation. Okay, and that's where physical examination can start to guide you into findings. So that will be associated with a murmur that's often heard posteriorly, and a systolic murmur maybe at the front of the chest. And again, we'll talk about murmurs. For a coarctation to cause radial delay or dysynchronous pulses, it'd have to be in an unusual position. Obviously, it'd have to be like that, which is a little bit unusual. So most times that you get a dysynchronous pulse is actually due to disease in the arteries of the arm rather than a slightly unusual coarctation. But radiofemoral delay is a very important thing for us to look for in terms of the pulse and synchronicity of the pulse. And you'll also remember that we have peripheral pulses. So as a cardiologist, I may be guilty of not examining them particularly well, but you remember you have your popliteal pulse and your posterior tibialis and your dorsalis pedis pulse, which again can give you an idea of the whole circulation of the body. So if you were all in an exam and the professor taking the exam or the OSCE said to you, OSCE is a term that we use about a practical exam. Please examine this patient's pulse. It may be that what they're wanting you to do is all of this. Check all the pulses, check for synchronicity, check for radiofemoral delay, and if you haven't picked up anything, then check for the peripheral pulses. And over the larger pulses, you will also want to take your stethoscope and listen for what we call bruits, B-R-U-I-T, bruit, which is a sign of turbulent blood flow in the great vessels, as opposed to a murmur, which is turbulent blood flow over the heart valves. So, a bruit in the neck or bruit over the femoral arteries might be important for cerebral vascular disease or peripheral vascular disease. Okay, so that would be the very basics of the examination of the pulse, okay, and what you might be asked for. So I often, when I'm teaching students, say, let's talk about examining the cardiovascular, I say, work out from the fingers to do the general examination, concentrate on the pulse, then check the blood pressure, which I'm sure you've had practicals about checking the blood pressure. And then the next thing you come to is the jugular venous pulse, okay? And the jugular venous pulse is an important tool for us in our physical examination of the cardiovascular system. Can anyone tell me why a cardiologist might be interested in the JVP or jugular venous pulse, and with that also the jugular venous pressure? Why would we be interested in that?
Because it's measurement the pressure in the right atrium.
Yeah, exactly. So this is our way of staring directly into the right atrium. So again, you remember that I said we want to examine our patient from the right side, and the reason is that we're interested in the jugular vein, the internal jugular vein, and on the right side that runs in a straight line down to the right atrium. And there are no valves. There are no valves in that course of the vein there. So when we look at a column of blood, it is reflecting just what is in the right atrium. Now, you need to know where to look for your jugular venous pulse, and that's where the sternocleidomastoid muscle comes in. You remember the sternocleidomastoid, I'm trying to demonstrate it myself, has two heads. There's one head there, and there's one head there, and reach up to a common insertion point. And that anterior triangle there, bordered by the heads of the sternocleidomastoid, that is where the jugular venous pulse emerges, and it travels in a direction up towards the angle of the jaw and the earlobe. So when you're examining the patient, you need to know where to find the jugular venous pulse, and you start and you examine with the patient at 45 degrees, as in my little demonstration here, 45 degrees, and we're looking along that line for the typical pulse of the jugular venous pulse. It's a very typical pulse. Does anyone know what the pulse of the JVP looks like? That's maybe asking too much to describe it verbally. Okay.
You, Dr. Peter, ask as much as you want. It's like it's a great pleasure for us, honestly.
So anyone know what the JP looks like?
It
Or what the
has
pulse-
2 beats.
It
It
has
has
2
2
beats.
beats rather than 1 beat.
Yes.
It
So
varies
it's-
with the position, not
Yes.
rather than independent of position as the carotid artery. It's improbable, and it when we put the patient in 45-degree, he is increased and downward.
Okay, I didn't quite catch that last bit, but I'm very impressed with your knowledge as a first second
And
year.
raise with the abdomen pressure.
Yes, you can squeeze over the liver.
No, I'm 5 stage.
You're
It's increase with the pressure. Abdomen
Okay.
pressure.
Okay. Very good. And Dalal, I saw a hand up. Dalal, are you going to say it? Okay. So what we're looking for, I'm going to take the first bit of your answer there. You've said lots of very good things. So the first thing is to identify the waveform of the JVP, okay? And the waveform is biphasic. There's my pen, there's a pen. The waveform is biphasic. So it's an interesting waveform. It does this. It has 2 phases to it, okay? And we describe some letters associated with this. We call this the A wave, and we call this the B wave. And that's unfortunate because I think that causes an awful lot of confusion in people. Okay? So as well as the A wave and the B wave, which are important letters, we also have a C wave. And we have an X descent and a Y descent. Okay? So I want you to think, if we are looking at the JVP and we're looking right down into the right atrium, what might happen in the cardiac cycle to make the pressure or the pulse rise in the jugular vein? What might cause this A wave? Anybody?
Doctor, change the position of the patient to rise the JVP.
You can, but what I'm interested in, what actually causes this? What causes this first peak of the JVP, of the A wave? Does anyone know? If we're looking down into the right atrium and the heart's doing something, what could be happening to raise the pressure there and cause this A wave? Anybody? Remember, there's
Doctor,
no
intrathoracic pressure when inspiration, intrathoracic pressure when inspiration and expiration.
No, that's not what causes it, but I am going to come to that later. So what causes the A wave is when you have atrial contraction. Because again, there's no valves. So when the atria contract, the pressure goes up. And that's what produces this A wave, the most noticeable bit of the JVP.
You mean the SA node, the electricity of the heart?
No, so if you think about the heart, there are ventricles and atria, and the cardiac cycle goes. Okay, so the atria on top of the heart, what sometimes are referred to as the filling chambers, they give a kick of blood to go into the ventricle. So the ventricle will fill in diastole on its own, and as it fills up, just before it's about to contract, the atria will contract to squeeze some more blood in, so that every heartbeat is as efficient as possible. So that's the atrial contraction. And if you look at your ECG, have you all done ECGs, yeah?
Yes.
If you look at your ECG, you know that the spike in the ECG is the onset of ventricular systole. So ventricular systole is happening here. Sorry, we know that the spike is ventricular systole, and so that the gap in between the spike is ventricular diastole. Does that make sense? And we see the P wave, which heralds atrial systole. So atrial systole happens right at the end of ventricular diastole and just before the ventricle contracts. So it's the heart does this. The ventricle in diastole will suck blood in, and so the atria contracts immediately before ventricular contraction. And so if we're looking down into the atria, we will see we will see the change in pressure as the atria contracts, and that will produce the A wave. So the A wave tells us that the atria are contracting, or the right atrium is contracting. That's what causes the A wave. That's important to know, because when we start to talk about abnormal JVPs, you need to know what causes the normal one. And this is where the JVP becomes difficult, because they chose to call this second wave the V wave. And people always think, well, if the A wave is the atrium contracting, the V wave must be the ventricle contracting. But that is wrong. That's where it starts to get really confusing, and it's confusing for medical students. Immediately after the atrium contracts, the ventricle will contract. And we know that it happens when we see this C wave. Now, the C wave, I'll be honest, the C wave is very difficult to spot clinically in a patient, but it is there. If you put a pressure manometer in, you would see the C wave. And the C wave is caused by the reverberation of the tricuspid valve closing. Boom. Okay, so you see that little shudder as the tricuspid valve closes, as a little bump in the JVP. Okay, so we know that if the C wave is the tricuspid valve closing, then we know that that must be the onset of ventricular systole. So if that's the onset of ventricular systole, the V wave cannot be anything to do with the ventricle contracting. So the X descent, so we've had the atria contract, it's given us the big wave, and then the X descent is the atrium relaxing. And as the atria relaxes, the jugular venous pulse or pressure will fall. So we'll see the C wave as the ventricle starts to contract. The tricuspid valve stops us seeing what's going on in the ventricle, and the X wave is the atria relaxing. So now we've got to figure out what on earth causes what on earth causes the V wave. So the filling of the blood into the heart takes place continuously. Okay, so we now have a situation of the atria is relaxed. We're now in atrial diastole. The tricuspid valve is closed, and blood is returning to the heart through the vena cava and starting to fill the atrium. And it's that filling with the tricuspid valve that causes the V wave. So V equals atrial filling with a closed tricuspid valve. Okay? And then something must happen to cause the Y descent. And you remember me doing this, so, okay? That's the ventricular diastole. So ventricular diastole, it takes a long time and fills the ventricle without the atria doing anything. The atria is the actual kick at the end. So what's happening with the V wave, the atria starts to fill up, then the ventricle ends systole and goes into diastole. So we know that ventricular systole ends here, and the Y descent is the atrium emptying into the ventricle as the tricuspid valve opens. Okay? It's very important that you guys understand what the A and the V wave are and how the C wave in the JVP actually signifies when ventricular systole is. And the reason for that is the JVP becomes a very useful tool in looking at certain pathologies. And I would be, and again, I will build on this if you want me to come back and start to talk about how you can use the JVP or the jugular venous pulse to diagnose certain cardiac problems, okay? But for the moment and for the basics, try and get into your head what A, C, and V mean, and that will follow about what X and Y are. And once you've got that, then we can build on that to look at what the JVP does in pathology, okay? Now, there's a jugular venous pulse and there's a jugular venous pressure, okay? So the normal pressure in the right atrium is about 5 millimeters of mercury. So in the old sphygmomanometer, we used to measure the blood pressure with a column of mercury. That's what our blood pressure numbers mean. And a column of mercury, a 5 millimeter mercury pressure is the equivalent to 7 centimeters of blood. And if we look at the patient, a normal JVP will be about 7 centimeters above above the right atrium. And in normal people, you may just see the head of the JVP just emerging from the clavicle, just at the foot of that anterior triangle. Okay. Now, when it comes to measuring the JVP, you might be asked to measure the JVP. And some people just look, oh, well, we'll just measure it from the clavicle and see where the top of the column of blood is. And they'll measure that out and say, well, that's 5 centimeters. Technically, that's not how we measure it. We need to measure it above where we think the left atrium is. And this is where I want to introduce you to an important landmark, a cutaneous or a landmark, a surface landmark. So if you feel on your sternum, the breastbone, the sternum is split into 3 sections: the upper, the larger mid, and the lower zippy sternum. But between the upper and the mid part of the sternum, there's a little line. If you all feel, you'll feel a little line on your sternum. That used to be called the angle of Louis, or the manubriosternal angle. Just so, have a wee feel, and again, on friends or partners, and that is a very important landmark. And the reason it's important is because just beside that is the second intercostal space. So you can count from your second intercostal space. You know that that is your second intercostal space. But in terms of the JVP, the way that you measure the JVP, technically measure the JVP, is you see where the column of blood is in the neck, and you take a line that's perpendicular to the floor, and then you measure down to the manubrium sternum like that, okay? So that's how you would measure it, and it would be that distance, which is the height of your JVP. Okay, then again, that's might be old-fashioned, but that's technically how you measure it. Now, I'm just seeing that there's some chat. Am I missing some questions? Yes, so there's a question here. How difficult is it to measure the pulse in an obese person? Sometimes you can't, sometimes you cannot see the JVP. So in someone who's got a lot of obesity, it can be very difficult, but it's a very useful sign if it's there. Okay, thank you for that question. So I would encourage you, as I say, to start to get used to this JVP and knowing what happens to make these waves. And the next time I come back, we'll start to have some fun with the JVP. Okay.
Dr. Peter, hello. So
yes, have I run out of time?
okay, so are you done now? Yeah?
No, I can keep going if you want. To go, I was going to do a little bit about auscultation.
Okay, so you feel free, whatever you love. So because we need to give 10 minutes for questions if there are some questions.
If everybody's happy, I'll just go on to the next bit that I wanted to talk about.
Yeah, go for it. Yeah, sure. Cool.
Okay. So
yeah, thank you.
With this, I'll just jump. When we get to the chest, the examination of the chest, there's a little mantra. I don't know if you know what I mean by a mantra, but a little thing, a little routine that you need to start working through. And that is inspection, palpation, percussion, and auscultation. If you start to structure your examination of the chest and the heart around that, that will mean you've got a very systematic approach to the heart examination. We don't really percuss the heart anymore. It's a skill that's lost to us, but it used to be done, centuries ago when people were percussing out the dullness of the cardiac, the cardiac shadow. For example, in very enlarged hearts or pericardial effusions, you could actually tap it out. But it's a skill that's lost to us. So we will start to talk about inspection, palpation, and percussion. But I thought we would just spend 5-10 minutes on auscultation. So I would encourage you all to get a good quality stethoscope. There are studies that show it doesn't really matter what your stethoscope is, but and I'm not a salesman, but a Lippmann stethoscope, they're very good. A run-of-the-mill stethoscope like that is perfect, or if you want to go for the super duper, very expensive, high-tech electric stethoscopes, they're all there, but Lippmann is a very good stethoscope. But whatever stethoscope you have, I want to explain 1 or 2 things about auscultation. Okay, and I appreciate I'm jumping straight to auscultation here. We have certain areas that we listen to on the heart, okay? And this is where this manubrium sternum becomes important for us again, okay? Because these areas are the second intercostal space, just to the right of the sternum and just to the left of the sternum, are very important areas. We call the second intercostal space to the right of the sternum the aortic area, okay? And it's so called because that is the area that we will hear the murmur of aortic stenosis, which is a narrowing of the valve the best, okay? And similarly, on the left side, we call that the pulmonary area, okay? Now, these 2 areas here are nowhere near where the valves are. The valves sit much further down in a little zigzag line like that in the lower part of the sternum. So the reason that we listen there, again, if I go back to my drawing, a murmur is a sound of turbulent blood, okay? turbulent blood flow. Turbulent blood flow created by disease in the valve. So for aortic stenosis, that is created when there's narrowing or disease in the valve and the ventricle pumps, okay? And it pumps blood across the aortic valve into the root of the aorta and the ascending aorta. And that means that the murmur will be loudest in this direction, okay? And if we think about that on our subject here, you've got the left ventricle sort of pumping in this direction into the aorta, okay? So that is why we will say that the aortic area is in the second intercostal space, okay? The pulmonary area, the exact opposite. So our pulmonary artery is, our pulmonary valve is hidden in behind that, and our pulmonary stenosis murmur is going to go in that direction. So it is over on the left-hand side, okay? So our aortic and pulmonary areas are so named because that's where the murmur or stenotic murmurs are best heard, okay? The other areas we listen to are the lower left sternal edge and out at the apex beat, okay? Now what I'd like you guys to start to hang everything on is the first and second heart sound. So again, in between the first and second heart sound is ventricular systole. So when the ventricle starts to contract, the left and the right ventricle, the valves that close will be the mitral and the tricuspid valve, okay? And the first sound, and we traditionally write the first sound with a Roman numeral like that. The first sound is largely created by the mitral valve. The tricuspid valve closes very quietly and doesn't have a great deal to add. It's not got much of a contribution to the first sound. And the first sound when you're listening with the stethoscope is the sound that goes lub. Lub. And the lub, if you were feeling at the carotid, the lub will happen just before you feel the carotid pulse. And at your stage, it's quite acceptable to feel the carotid pulse, to feel the pulse whilst you're listening, okay? So lub is the first sound, largely of the mitral valve closing, okay? So the mitral valve closes, the ventricle contracts, and it pushes blood through the open pulmonary and aortic valves. And then when the ventricle relaxes, the pressure in the ventricle falls below that of the pulmonary tree or the aorta, and the aortic and the pulmonary valve close to form the second sound, okay? Which we traditionally go like that. So, lub-dub, lub-dub. And you guys now need to be experimenting with your stethoscope and getting your ears attuned to lub and dub, because everything hangs on the lub-dub, the first and second sounds. And you know that between lub and dub is ventricular systole. So between lub and dub is where you'll get the murmur of aortic stenosis or pulmonary stenosis. Lub-dub, lub-dub, lub-dub. And you should concentrate on getting your ears into hearing the lub-dub. Now, one of the students made a very good point about the JVP. And I'd just like you to think about what happens when we breathe. So when we breathe, we flatten our diaphragms and we pull up the bucket handles that are our ribs, and we increase our interthoracic volume and reduce the pressure. And because nature doesn't like that, we draw in air, but we also draw in blood back to the heart. And that has some effects. That has some effects on what happens to the heart. So does anyone know what happens? There's two things in particular that I'm interested in when you take a breath in. One thing affects the rhythm, and the next thing affects what we listen to. Does anyone know what happens to your heart when you breathe in terms of your heart rate? I should say, not rhythm, rate. Anybody? Yep, I see a hand up. Speak to me.
Haidar Qasim, go ahead, please.
I think when someone breathes in, the heart rate will increase.
Yes, that's right. The heart rate increases as a response to more blood going to the right side of the heart. And we call that sinus arrhythmia. Sinus arrhythmia, which is completely normal, particularly in young people. So I would imagine that many of you will still have sinus arrhythmia. As you take a breath in, your heart rate very slowly increases, and as you breathe out, it decreases again. And you often see that on ECGs. You can tell when people are breathing, okay? But the next thing, and it's the next little basic of what I want to finish on tonight. If you take a breath in and you get more blood filling into the right side of your heart, what will happen is the pulmonary valve will close slightly later than the aortic valve, okay? So what you get when you take, what you may get when you take a breath in, and this is important if you're listening to your own heart, or you're listening to friends' hearts, or partners' hearts, or patients, as you breathe in, the second sound will split, and you will get your second A2 sound, the component that's caused by the aortic valve, and the P2 sound coming slightly later. And we call that a split second sound, or splitting of the second sound. And it is completely normal in young people. Okay? So if you hear something funny happening to the second sound as you're listening and you breathe in, that is normal splitting. And as you breathe out again, the two sounds will come back together. And that's called physiological splitting. Okay? So have a wee look out for that. Now, there are two other sounds that you will come across. There's the third heart sound and the fourth heart sound, okay? Again, in young people like you, particularly athletic people, the third heart sound can be completely normal, okay? And it's a sound of rapid ventricular filling, okay? If it is in an old person, particularly if they have heart failure, and it's mixed up with a tachycardia, that third heart sound, lub-dub-dub, 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 sounds like a horse galloping. Lub-dub-dub, 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 lub-dub-dub. And that third heart sound we call a gallop rhythm, and it's an indication of heart failure. The fourth heart sound is usually pathological. You don't tend to get that in young people, and that's usually when an atrium contracts. So it's the onset of atrial systole into a stiff ventricle. And it's a wee dub that happens just before the first sound, okay? So we can talk a wee bit more about third and second sounds later, but I'd like you to concentrate on, as you go into the wards and the clinics, and you're starting to listen to the heart sounds. Again, the areas, aortic, pulmonary, lower left sternal edge, sometimes called the tricuspid area, and the apex, and then start to hang everything on lub-dub, lub-dub, and if necessary, feel with the carotid to get your lub-dub timing. So lub, carotid pulse, dub. Lub, carotid pulse is spelled dub, and that's you confirming the lub-dub. Okay. So I did say that I would stop and give a little bit of time. So that's us done the first wee bit of basics about the cardiovascular examination. It is basics, And I will be happy to build on all of this in terms of the pathology of the JVP, some of the characteristics of the pulse, and then start to talk about some of the murmurs at another time. But that's probably enough to go on for tonight. But I will be very happy to answer questions on cardiology in terms of what I've done, or indeed anything else that you've come across that you've got a question about. So I'll hand things over to you guys now. Yeah, so I see a question.
Yes, doctor. Doctor, it's about JVP. Some condition has chronic congestive heart failure, and there's
Yes.
elevated in JVP, but I can't see the pulses.
No, so it's sometimes quite difficult. Okay, so what the an elevated JVP in heart failure or right heart failure in particular shows general overfilling of the venous system. And again, the giveaway, your colleague went through about the ways of telling the difference between the JVP and the carotid pulse. And again, that is a good examination question. So if you've got a very high JVP, it might be up at the angle of the neck. Or
behind the hair.
Yeah, or even you might just see the earlobe twitching.
Yes.
What you do, if you think you've got a very high JVP and you can't quite see it, then you bring gravity in and you sit your patient up. And as you sit the patient up, the JVP will fall a little and then you'll start to see the pulsation. So that's sometimes when you think it's there. If you sit the patient up, you'll maybe see it a bit better. But as one of your other colleagues said, sometimes in people who've got big neck or obese, it can be very difficult to see. It's a thing that requires a lot of practice to identify.
Thank you, doctor, for this session. It was amazing, and I will soon give the next lecture for this. I wait there.
You're kind. I hope it has been useful to you. Any other questions I could help with?
Guys, if you got some questions, just feel free to ask, please. Dr. Peter, ready?
So there's a question on the chat. In case of an abnormal heart rhythm, should we think of chronic or sudden causes? Well, the answer to that is an abnormal heart rhythm could be both. So, for example, there are people, as we get older, we're more likely to develop this heart rhythm called atrial fibrillation, which often is a permanent or chronic problem. And that's what gives us our irregular pulse. Okay, so that's a heart rhythm that's chronic. So again, when you're a bit further on, I would be happy to give you a tutorial on atrial fibrillation. It's something I teach the medical students here on, but so that's a chronic one. But you can have a sudden heart rhythm problem. So if you have a myocardial infarction, you can suddenly develop ventricular fibrillation that would cause sudden cardiac death, or ventricular tachycardia, which sometimes is pulseless, is not associated with the heart beating, or sometimes can be associated with a pulse, but is a rapid heart rate, and that would be a sudden heart rhythm problem. And on the other side of the coin, the heart rhythm going very slowly. So some people they just suddenly go into a complete heart block or ventricular standstill, and they will present with syncope. They will collapse, and they'll either come round very quickly, which is the hallmark of cardiac syncope. So there are both sudden and there are chronic abnormal heart rhythms.
Great. So Dr. Peter, thank you very much. I would like to tell you, like Dr. Adnan just messaged, and he's apologizing for not attending today. He's at a conference and he's presenting right now in Dubai. So he's extending his warmest wishes to you, and he's so grateful. And Dr. Mudar said, still at work with emergency cases, so unfortunately he couldn't make it today. He was trying, but I think you know what's going on. So
he might well be in the hospital next door to me now. I'll go and find
exactly,
him.
you might see him like at some point. So Dr. Peter, we are so thrilled. Honestly, we are so your workshop, your lesson, the lecture, call it what you call it. It's so captivating. Honestly, I loved every single bit of it. Honestly, like from the visuals you use, the way you express things in very simple language and accessible to students. It's such a distinctive lecture. We definitely would love to see more, and we are so glad to have you. Honestly, we really appreciate it.
If you and the students like what I do, I will be happy to come back and I'll start developing on these building blocks we've done today, and I'll speak to Mudar about the next dates that are available.
Definitely, we would love to see more, and hopefully we see you again at the medical school. I cannot wait to see you again. Thank you very much for your time and your efforts. Thank you very much, Dr. Peter. Goodbye.
Good night to you all, and I hope you have a lovely warm night in Iraq. It's not so nice here anymore.
I'm in Newcastle, actually. I'm in Newcastle.
Oh, Newcastle.
Yeah. Yeah.
Well, you'll be getting the rain as well.
Yeah, it was raining yesterday, actually. Yeah. Have a good night. Thank you very much. See you soon. Cheers.
Bye-bye.
Bye. Bye.